Hello everyone, this is the second part of the infertility lecture which we will be taking. Previously in my first video, we have spoken about infertility in the males. So, male infertility has been covered in previous video. You can just go through it to get the correct analysis of how to do the evaluation of the male counterpart. Now, in this second video, we will be talking about female infertility. So, in female infertility, if you consider the female genital organs, you have the uterus, the fallopian tubes, the ovaries, and then the cervix and the vagina outside. So, infertility can be in various parts of the genital organ, that is, it can be in the outlet. So, there can be outlet obstruction which can lead to the sperms not traveling upwards. Then there can be defect at the level of the cervix. There can be defect in the endometrium. So, endometrial lining defect can be there, which will not help in implantation of the fetus. Then there can be defect in the fallopian tubes, and finally there can be an ovulation, that is ovulatory defect. So, these are the various levels at which female infertility can occur. So, let us start with the ovary. So, if we consider the ovary, there can be three types of defects. So, WHO, there is a WHO classification of class 1, class 2 and class 3 type of ovulation defects. So, class 1 constitutes 10% of the cases, class 2 is most common, which constitutes 85% of the cases, and your rest of the 5% are constituted by class 3. Class 2 constitutes of hypo cases, that is hypogonadotrophic hypogonadism cases. This means the defect is higher up in the hypothalamus or the anterior pituitary, hypothalamus or anterior pituitary defects. So, ऊपर से defect है जिसके वजह से LH FSH is not secreted, and if LH FSH is not secreted, then the ovaries do not secrete estrogen and progesterone. So, this defect is hypo. Class 3 consists of hyper hypo defects. Hypo means hypergonadotrophic, means more and more secretion of FSH and LH from the anterior pituitary, whereby ovary mein there is defect, that is there can be premature ovarian failure or premature ovarian insufficiency or any defect in the ovaries. That, for example, there can be Turner's syndrome where there is 45XO, where the ovaries are failing already. So, despite high FSH and LH, the ovaries are not secreting estrogen and progesterone properly. So, all the cases of hypo, that is hypergonadotrophic hypogonadism, come under category 3. Category 2 consists of normo means normogonadotrophic normogonadism, means FSH and LH are also normal and estrogen is also normal. So, what is the defect actually? Defect is in the form of an ovulation because of there is no formation of progesterone. So, progesterone hormone ka defect hai, but estrogen is normal, is type 2. So, the classical example of type 2 is PCOS, polycystic ovarian syndrome. I have a separate video on PCOS, kindly go to my channel, I have tried to describe it in detail. So, PCOS wala video you can look in a different chapter. So, remember these are the three types of WHO class of ovulation defects or defects in the ovary. So, what will be the treatment? If it is class 1, then it is hypo. So, defect is either in the anterior pituitary or defect is in the form of in the level of hypothalamus. So, you have to give the hormones there and itself. So, your treatment will be pulsatile GnRH therapy, pulsatile GnRH gonadotrophin therapy. GnRH therapy has to be given so that the estrogen starts secreting, the ovaries start secreting the estrogen. If it is class 3 defect, then the defect is in the form of ovarian defect in the level of ovaries. So, you have to replenish the patient. Treatment is in the form of estrogen and progesterone you have to give, estrogen and progesterone therapy you have to give, because GnRH or FSH and LH are already high. It is the defect in estrogen progesterone. So, E and P you have to give cyclically in the form of either oral contraceptive pills or something like that. And if it is class 2 defect, then it is in the form of PCOS. There you have to go for ovulation induction, because these patients have difficulty in ovulation, that is egg release होने में problem होता है, then we have to go for ovulation induction. Now let us read how do we generally do ovulation induction in patients of PCOS. Okay. So, ovulation induction is an important topic which comes as a short note in your examination. Now, ovulation induction में basically what will happen? This is the ovary. Okay. So, ovulation, all you have to recruit the follicles, and follicles will then recruit and form the dominant follicle. It will rupture and then it will form the corpus luteum will be formed. So, what we do is, for that we have two types of agents. Either we give clomiphene citrate is a drug which is given, or you have number 2, you can go for letrozole. Clomiphene citrate is selective estrogen receptor modulator, whereas letrozole is aromatase inhibitor. Now understand what actually is aromatase. Aromatase helps in conversion of testosterone to estrogen. So, if aromatase is inhibited, then testosterone to estrogen conversion won't take place in the body. So, estrogen level will go down. When the estrogen level will go down, this will give a stimulus for the persistent estrogen won't be there. So, estrogen level will go down. Estrogen level going down will be a stimulus for the LH to surge, and then the LH will thereby help in ovulation and thereby production of progesterone. Okay. So, the vicious cycle of always having hyperestrogenemia in the body will be prevented by aromatase inhibitors letrozole. Similarly, the clomiphene citrate will have, since it is selective estrogen receptor modulator, it will have estrogenic property in some organs and anti-estrogenic property in certain other organs. So, the anti-estrogenic property of clomiphene citrate will help in reducing the estrogen height or the estrogen peak, and thereby the LH will rise and then there will be ovulation. So, basically the defect was the constant rise in estrogen, which will be brought down by these drugs. Okay. So, they will lead to ovulation. Now, letrozole, what is the dose of letrozole? You give 2.5 milligram tablet. 2.5 milligram tablet is given once daily from day 2 to day 6 of the cycle. Okay. So, if you consider this as the cycle, okay, let us consider this as the cycle, whereby this is day 1, the first day of the menses, and this is day 28, the last day of the menses. If it is a 28-day cycle, then we have our ovulation at around day 12. So, what actually happens is, when the patient will have menses, from the second day onwards, day 2 onwards, you start to give the ovulation induction drugs for 5 days, that is day 2 से लेके day 6 तक 5 दिन तक you give the ovulation induction drugs. If you give letrozole, you start from 2.5 mg. If you give clomiphene citrate, you start from 50 mg tablet. Okay. Then you give for 5 days. After that, what you do is you call the patient for TVS monitoring, transvaginal scan, whereby we will do follicle monitoring, follicular size monitoring. Okay. So, follicular size, we will see ki whether follicles are increasing in size or not after giving the letrozole or clomiphene citrate. If it has not increased in size, then in the next cycle we will increase the dose of clomiphene to 100 milligrams, and then we can give up to 150 milligrams. Similarly, letrozole dose can be increased to 2.5 to 5 milligrams, and then to maximum of 7.5 milligrams can be given. So, this is called the stepping up regimen. In step up regimen, we keep on increasing the dose until we get ovulation. Okay, so until the patient ovulates, we will keep on increasing the dose. So for the first 5 days, we will give the ovulation induction agents. Then we will call the patient from day 9 onwards every alternate day until the follicle size increases to 18 to 20 millimeter. 18 to 20 millimeter size of the follicle is called dominant follicle, okay. And this dominant follicle size of 18 to 20 millimeter is going to hatch or rupture, and this follicle will lead to ovulation once it ruptures. Okay, so 18 to 20 mm तक जब तक नहीं हो रहा है, every alternate day we call the patient for transvaginal ultrasound, whereby we monitor the growth of the follicle. Okay, then the day on which it is 18 to 20 mm, either we can wait for spontaneous rupture or we can give injection HCG, that is human chorionic gonadotrophin, which has similar action to luteinizing hormone of the body. So when you inject HCG, after 36 hours of injecting human chorionic gonadotrophin, ovulation occurs, because I told you that after there is LH surge, the LH increases for the next 24 hours and then it remains at peak for the next 12 hours and then ovulation occurs. So a total of 36 hours is taken for LH to act. Similarly, HCG injection also takes 36 hours to act. So that is why after 36 hours the ovulation occurs. Now how do you actually know that ovulation has occurred? What are the tests of ovulation? Very important question. Tests of ovulation. How do we know that a female has really ovulated or not? So the test for ovulation can be divided into indirect tests. It can be a direct test or it can be conclusive test. Conclusive test is 100% we know that ovulation has occurred. This can be possible only if patient become pregnant. So pregnancy is a conclusive test for ovulation. Direct test for ovulation will be by laparoscopy. By laparoscopy, you can see inside the abdomen that ovulation has taken place and corpus luteum has formed. So direct test is through laparoscopy only. But every time it is not possible to do laparoscopy because it is costly for the patients. Also, we cannot wait for the next 14 days and then do a urinary pregnancy test. So 14 days तक कोई बैठा नहीं रहेगा ovulation test करने के लिए. So basically we rely upon the indirect test for fast diagnosis of ovulation. So what are the indirect tests? Number 1, there is change in basal body temperature, BBT. There is change in basal body temperature because progesterone hormone is thermogenic. Progesterone hormone is thermogenic. So progesterone hormone से temperature body का बढ़ जाता है. कितना बढ़ता है temperature? 0.5 to 1 degree Fahrenheit or 0.25 to 0.5 degrees Celsius increase in temperature occurs after ovulation, which is maintained for the rest of the cycle. That is secretory phase में the temperature remains high every day, and this falls 2 days prior to the next period. Okay, so in the second half of the cycle temperature is high. So every day keep on measuring the temperature. Once the temperature is a bit high, you know that ovulation has taken place, corpus luteum is formed and progesterone which is secreted has increased the temperature of the body. Number 2 test which can be done is cervical mucus study. Cervical mucus can be studied. Cervical mucus is in the first half of the cycle, it is stretchable. The stretchability is found in first half of the cycle, which is also called spin barket. Spin barket is found in first half of the cycle, whereas second half of the cycle under the effect of progesterone, the stretchability decreases and this is called TAC, T-A-C. This is called TAC or reduction in stretchability. So reduction in stretchability is called tac, and it is found in the second half of the cycle after ovulation. Similarly, there is decrease in ferning pattern when seen under microscope. So, these are the changes which occur in cervical mucus. The third change which we can find after ovulation is in vaginal cytology. So, vaginal cytology, how do we take a vaginal cytology? We can take a vaginal cytology in the form of a pap smear. So, pap smear जैसा एक smear we can take, and then from the vaginal cytology, and we can see. So, there will be shift to the left in vaginal cytology. Now, what do you mean by shift to the left? So, when you see vaginal cytology, there are three types of cells which are found. Number one is your basal cells. Basal cells we write in the left side, then followed by your parabasal cells. Parabasal cells को लिखा जाता है बीच में, and right में लिखा जाता है all the superficial cells. So, vaginal cytology जो होता है वो ऐसे लिखा जाता है, vaginal cytology 0, 50, 90. इसका मतलब है कि 0, 10, 90 you can write. It means there are no basal cells, 10% are parabasal cells and 90% are superficial cells. Vaginal cytology 0, 50 and 50. It means 50% parabasal, 50% superficial cells. So, superficial cells are formed more under the effect of estrogen. So, first half of the cycle is made up of superficial cells, whereas second half of the cycle progesterone makes the parabasal cells more predominant. So, there is shifting to the left, that is the left hand side cells number increase and right hand side cell number decreases when there is ovulation. Number 4, you can go for ultrasound. In ultrasound, what are the picture which is seen after ovulation occurs? Number 1, after ovulation has occurred, the endometrium becomes trilaminar. So, 3 line बन जाएंगे and thick endometrium बन जाएगा. Trilaminar ultrasound after it has ovulated under the effect of progesterone. Number 2, you will find a little bit of fluid in the pouch of Douglas. Fluid in the pouch of Douglas, POD, which is suggestive of ovulation. After ovulation, there is a fluid which is secreted from the ovary because there is rupture of the corpus luteum, and this fluid comes and gets deposited in the pouch of Douglas. Number 3, what do you find? In the ovary, you find the corpus luteum. So, corpus luteum and the dominant follicle which was already 18 to 20 mm, this has disappeared. So, these are the findings which you find in ultrasound. The number 5th finding which you find can be in endometrial biopsy. In endometrial biopsy, if you take a biopsy in the day 21 of the cycle, day 21 to 22 of the cycle, if you take an endometrial biopsy and it shows secretory endometrium, that is the glands are formed. If secretory endometrium is found, then it is suggestive of progesterone present. This means ovulation has taken place. But if it is still proliferative endometrium, that is the first half of the cycle का endometrium अभी भी है endometrial biopsy में, then it is suggestive that there is no progesterone till now. It is under the effect of estrogen only. So, it means ovulation has not taken place. The 6th thing, indirect evidence which we do for ovulation is hormonal estimation. You can go for hormonal estimation. So, you can go for serum progesterone estimation. Serum progesterone test कराते हैं at day 21 to 22. If the progesterone value is less than 1 milligrams per ml, if it is less than 1 milligram per ml, then it is suggestive of an ovulation. But if it increases to more than 3 to 6 milligrams per ml, then it is suggestive of ovulation has taken place. Similarly, you can go for serum LH estimation, whereby LH also increases, surges and gets up to a peak of around in the afternoon when the ovulation has taken place, around the ovulation time. So, these are the 6 types of indirect tests which can be done to test for ovulation. Now, after this you have done, after you have seen whether patient has ovulated or not. So, these are the defects which you find in the ovary. Once the ovarian defects are not there, you have ruled out them, then next we evaluate the patient for ट्यूबल पेटेंसी टेस्ट. ट्यूबल पेटेंसी टेस्ट अब देखना ज़रूरी है कि ट्यूब्स पेटेंट है कि नहीं, ट्यूब्स में कोई दिक्कत तो नहीं है. सो फॉर ट्यूबल पेटेंसी टेस्ट वी गो फॉर हिस्ट्रोसैल्पिंगोग्राफी. Hysterosalpingography is a test whereby dye is injected in the uterine cavity. The dye travels through the tube and then goes and gets spilled up into the peritoneal cavity. So, if there is defect in any place of the tube, then you really come to know whether the defect is there or not. So, for tubal factors we go for HSG. HSG I have a separate video, kindly look for the HSG video whereby you will find how HSG is done, what are the dyes which are taken, how much of dye is taken. These will be asked in your examination. Of course, it can be either a spotter or it can be OSCE or table viva questions are already there. So, you just have to look at that video. Now, see tubal factor में defect क्या क्या हो सकता है. There can be defect in the proximal part of the tube. So, there can be proximal tubal blockage, there can be mid segmental tubal blockage or there can be distal tubal block. Okay. So, apart from HSG, what all other tests which can be done to look for these things? There can be tests whereby you can go for saline infusion sonography. Okay, HSG तो मैंने बता ही दिया. Apart from that, you can go for laparoscopic chromopertubation. Laparoscopic chromopertubation, which is also called CPT, chromopertubation. These are the tests which are done. Okay. So, if there is tubal factor infertility, what you can do? If there is tubal factor infertility, you can go for the treatment will be tubal canalization, whereby you can go for canalizing the tube, canalization, or you can go for, this is also called tuboplasty. Tuboplasty operations can be done. The most common cause of tubal block is genital tuberculosis. Very, very important from Indian scenario. So, kindly go for a second video which I have on genital tuberculosis. Kindly look at that. Very common question, area of questioning which comes in your examination. Distal tubal block. In distal tubal block we go for fimbrioplasty, whereby the femoral end, actually distal tubal block में femoral blockage हो जाता है. So, you have to repair the femora, which is also called fimbrioplasty. And if still after operation the tubal block is not resolved, then finally you have to go for in vitro fertilization. IVF technique has to be taken for your treatment. Okay. So, these are the things which you need to know. Next, coming to your endometrial cause. Endometrial cause can be diagnosed. Okay, if there is problem, it will be evident in your endometrial biopsy. So, all patient of female factor infertility, they will undergo endometrial biopsy as a routine procedure for infertility management. Okay? So, endometrial biopsy, when do we get it done? Always remember, for infertility patients, you get the endometrial biopsy done on day 21 to 22 of the cycle. Day 21 and 22 पे अगर आप endometrial biopsy कराते हो, ठीक है, तो उसमें ये देखना होता है कि proliferative endometrium आ रहा है कि secretory endometrium आ रहा है, whether it is proliferative or secretory endometrium. If it is secretory endometrium, then it is well and good, our endometrium is okay, because progesterone का effect तब तक आ जाता है क्योंकि corpus luteum form हो गया है. But if it is still proliferative endometrium in day 21 to day 22 of the cycle, then you are sure that it is anovulation which is a cause of infertility in this patient. But if you think that patient का genital tuberculosis है, then your biopsy will be done on day 1 to day 2 of the cycle, that is first day of the cycle when the patient menstruates. Because अब हमें endometrial biopsy के साथ साथ we have to send the menstrual blood also, the menstrual blood for TB PCR, menstrual blood for TB polymerase chain reaction and AFB bacilli. This has to be sent. That is why our timing of endometrial biopsy is very important. अगर हमारे थ्योरी से ये लग रहा है कि पेशेंट को ओलिगोमेनोरिया है, एमेनोरिया है, more chances of genital tuberculosis, then get the endometrial biopsy done in day 1 to 2 of the cycle. Otherwise, it is better to get the endometrial biopsy done in second half of the cycle, where we diagnose कि हमारे anovulation है कि नहीं है. Once you have evaluated that, next we come to cervix. So there can be cervical factor infertility. Cervical factor infertility. Now what actually happens is, in cervical factor infertility, if you consider this as the uterus, then some people have some hostile secretions from the endometrial glands which kill the sperms. So sperms are killed. So there is anti-sperm antibody which is present in their cervical mucus. So we have to detect that. This, for detecting that, what we do is we generally do a postcoital test. Postcoital test. Postcoital test is, what we do is we ask the patient to come to us within 30 minutes of having coitus. Within 30 minutes of having a sexual intercourse, patient comes to our OPD and we take a cervical smear. Now this smear we examine. If this smear consists of viable sperms, sperms सारे viable है in the smear, then we tell कि there is no anti-sperm antibody. But if the sperms have been made non-viable by the anti-sperm antibody, then these sperms will not have any progressive motility. Progressive motility खत्म हो जाएगा in the cervical mucus. So it means कि there is anti-sperm antibody present. So this is called postcoital test, और दूसरा नाम इसका है सिम-हूनर्स टेस्ट. सिम-हूनर्स टेस्ट, very important, comes as a short note or comes as an MCQ question. In this case, what will be the treatment of choice? Treatment of choice will be IUI, intrauterine insemination, whereby we directly inject the sperms into the endometrial cavity so that they go upwards and gets fertilized in the ampulla of the tube. So we have to just bypass the cervical mucus for that. Okay. Apart from cervical factor infertility, there can be defect in the outflow tract. Outflow tract में problem हो सकता है. Patient can have imperforate hymen, these you all know, or patient can have transverse vaginal septum, तो उसका there is surgical management होता है, whereby cruciate incision is given and then all these things are done. Okay. Some patients have painful dyspareunia, that is they will have very much pain during sexual intercourse. So they will not undergo sexual intercourse and then they will have infertility. So in these patients, you can go for either lubrication of the genitalia so that there is no pain, or you can directly go for IUI can be done, or IVF. Okay. Better to go for IUI, whereby with the help of catheter we introduce the sperms into the endometrial cavity. When none of these factors have been found in evaluation, then patient is said to have unexplained infertility. Unexplained infertility, when you evaluate everything, evaluate the hormones and everything, still there is no cause found for infertility, then it is called unexplained infertility. In unexplained infertility also, the treatment of choice will be, we start with IUI plus controlled ovarian stimulation, COS plus IUI. Controlled ovarian stimulation is ovulation induction, which we do it either with letrozole or clomiphene citrate, followed by IUI. If it fails, then you have to go for in vitro fertilization. So these all things are the things which we generally do for evaluation of female infertility. So in this part of the video, this second video, I have told how do we evaluate for female infertility. Now one more thing which is left in infertility is detail of IVF and IUI, how we really do IVF, what protocols we follow, what we do for IUI. This I will make a separate video. You can refer to that video because many people won't be interested that much upon the further evaluation of IVF. Also remember, there is a test, a very important test called AMH, that is anti-Mullerian hormone test, which is done to look at the ovarian reserve. ओवेरियन रिजर्व मतलब कितने फॉलिकल्स है वो पता चलता है हमारे एंटी मुलेरियन हार्मोन टेस्ट से. एंटी मुलेरियन हार्मोन टेस्ट कैन बी डन ऑन एनी part of the cycle. You can get it done any day of the cycle. Normally the AMH level should be more than 1 nanogram per ml, and if it is very high, that is more than 5 nanogram per ml, okay, more than 3 to 5 nanogram per ml, then it is suggestive of PCOS, because PCOS people will have a lot of follicles in the ovary which will increase the anti-Mullerian hormone. So these are all the evaluations which we do in patients of female infertility. So thank you, and we hope to look forward for the video on IVF.